Good evening, dear friends and colleagues. Welcome to our third webinar for the Lebanese Fertility Society. It's one of multiple webinars that should cover until now a big part of our specialty. Big thanks for Merck to make it happen today. This evening, we are going to talk about fertility preservation, history and evolution. We'll talk about updates and new trends in preservation with the know-how of our best expert in the Lebanese Fertility Society. So I will talk a little about the evolution of the preservation. We know that reproductive aging is a natural process that occurs in all women. The problem actually with this theory is divided to two problems. The first is delayed motherhood. All women want to postpone reproduction, and this can increase the chance of a woman remaining involuntarily childless. And it will increase also pregnancy complications. The second problem is that cancer happens more and more frequently and more early in age. Age of fertility versus age of menopause. Normally, the average age of menopause is 51 years of age. 10% will experience menopause by 45, and 1% will experience a primary ovarian insufficiency. We know that 13 years prior to menopause, there's an accelerated decline in fertility. So if we take the 1% with primary ovarian insufficiency, or also we take the 10% that will experience menopause at 45, we'll have a very early decline in fertility. Then we have approximately 10% of women will have this decline in fertility around 32. Why it's a must to talk about preservation. From 1970 to 2014, the average age of first-time mothers in the US increased from 18% to 21%, from 18% at 26 years to 21% at 26 years. This increase in women entering the workforce, more advanced educational degrees, and greater use of contraceptive methods. So we have to preserve our fertility, achieve genetically related offspring. But we know also that preserving fertility is safe. A study of 1,027 children born from 804 pregnancies using vitrified oocytes compared to 1,224 children from 996 pregnancies with IVF using fresh oocytes. There is no significant differences between gestational age and delivery, birth weight, birth defects, and perinatal mortality. So we know now that preservation of fertility is safe for the offspring. Oocyte preservation is a solution. We know that the first pregnancy following oocyte preservation was in 1986 by Chen. After 2 decades, the experimental label for oocyte preservation was removed from the ASRM and the ISHTRE societies because we have an improved success and safety data. And this to push all the people to do oocyte preservation. The first report of a live birth from frozen thawed embryo was in India in 1978. And long before, Polge in UK preserved the first time spermatozoa in 1949. So fertility preservation was a problem in the last century and still a big problem for us today. 1983 was the first stillbirth human embryo in Australia, and the first human live birth was in Holland in 1984. So since 1984, we have pregnancies with normal deliveries from preservation of oocytes. So oocyte, from an ethic point of view, oocyte vitrification is a safeguarding future reproductive chances. We have to inform the whole population about possibility of fertility preservation. There is an urgent need in preparing future doctors and obstetricians as to how to initiate discussions with their patients about elective oocyte banking. It is unethical today not proposing and not doing it in 2020. Premature accelerated loss of fertility, there is a risk factors. Cancer with chemotherapy and radiotherapy, severe endometriosis, ovarian surgery, strong smoking, family history of early menopause, and many genetic problems like Turner and X-fragile. All these topics will be discussed in our webinar. Our chairman, Dr. Layal Abi Zeid, head of IVF Center in Hôpital du Levant, will introduce our speakers and will moderate our webinar. Thank you, Dr. Abi Zeid. The floor is yours.
Thank you, George. Thank you, all of you, all my colleagues. I'm honored to be with you today. Let me introduce Georges Abitayeh, associate professor at St. Joseph University, and he is the head of Obstetrics and Gynecology at Hôtel Dieu de France. He had a PhD in biomedical ethics, and he is the president, the actual president of Lebanese Fertility Society. Let me add to you, George, that we have one anxiety in our life as a woman is the most important is aging, and we prefer not to age. The plastic surgery had a big part in it. Still, the fertility preservation, even for social reason, is very important, and it will be discussed today by Dr. Azoury. We need very good results nowadays to say that we really fight age despite all the other circumstances and medical conditions you already discussed. Dr. Hady El Hachem will talk about the last updates in fertility in women with cancer, and Dr. Houssam Abdel Reda will talk about fertility preservation in endometriosis cases. So let me introduce Dr. Hady Hachem, who will talk about the last update in fertility preservation in women with cancer. He's USG graduated, Université Saint-Joseph, our French University of Medicine. He's a Canadian board certified endocrinologist and specialized in the field of onco fertility. He works at TMC and Bellevue. Hôpital de Bellevue. I would like to thank all the participants from all the country we have with us. Of course, Kuwait, Iraq, Jordan, France, England, Syria, Emirates, United Kingdom of Arabic Saudi, and of course our colleague in Lebanon. And I would like, of course, to thank Merck for sponsoring this webinar. the meeting will be recorded and shared on the Lebanese Fertility Society YouTube channel, and it will be aired from tomorrow. If you want to ask a question, you can write it, type it on the Q&A section, and then I will ask it at the end of the webinar. And if you prefer to have a direct question to the speaker, you can just raise your hand and the talk will be used. So please, I will leave the parole Dr. Hady El Hachem. Hady?
Can you hear me?
Yes.
Thank you, Layal, and thank you, Dr. George and the Lebanese Society for organizing this webinar and asking me to cover the latest updates in women with cancer. As you all know, nowadays, all international societies, cancer and OBGYN societies, recommend that all cancer patients be referred as soon as the diagnosis is made to a reproductive endocrinologist to discuss with them the risks of the cancer treatment. Because we all know by now that cancer treatment has a negative and irreversible impact on a woman's fertility. I'm not gonna go through the key effect of chemotherapy and radiation therapy. These are common knowledge by now. But instead, I'd like to talk about the new kid on the block, immunotherapy. You know, immune checkpoint inhibitors have recently changed the landscape of cancer treatment, especially for solid tumors and advanced stage disease. Now, you may argue that advanced stage disease, these patients are not candidates for fertility preservation, but oncologists will tell you that these drugs are soon to be used for all cancer patients. Take, for instance, the pembrolizumab, which is an anti-PD-1 inhibitor that was approved last year for the treatment of advanced stage melanoma. During that year, it has been registered in 92 clinical trials for use in the neoadjuvant setting and in patients with early disease. Unfortunately, we don't know anything about the impact of these drugs on fertility. The only thing we have right now is the NCCN guideline, which recommends contraception for at least 5 months after the last dose of immunotherapy. So this is a new challenge for us oncofertility specialists, and we hope that these trials will have, in their outcomes, will give us an idea about the impact on fertility and ovarian function.
Dr. Hachem, sorry,
Yes.
Can we have the slides because we cannot see the slides?
You're not seeing the slides?
No, can you share it, please?
Sorry. Can you see it now?
We're seeing Gibran Basil and Crocs.
Yes. That's good?
Yeah, perfect. Thank you.
So these are the fertility preservation options we can offer our patients nowadays. Some are classified as proven, some are controversial, and some are still considered experimental. We're gonna go through all of these, and we're gonna use the breast cancer as an example, because as you all know, breast cancer is the most common cancer in women of reproductive age. It is behind the most oncofertility referrals, and it offers the most challenges for our techniques. And I'm gonna start with the GnRH agonists. You know, some things in life are inherently polarizing, whether it's pineapple pizza, whether it's abortion, whether it's some political figures or celebrities, people can't really have a neutral opinion about them. They either swear by them or they swear at them. And this can be said for GnRH agonists in fertility preservation. For the last decade, the pendulum has swung between inactive and the positive impact and the negative impact. There has been 14 RCTs in breast cancer patients and 5 in other cancer patients. And today, there is still a big debate whether they work or they don't in the field of fertility preservation. Now, the recommendations differ between societies, but one thing they all agree on is that GnRH agonists should never be used in place of the proven fertility preservation methods. There seems to be a positive impact in breast cancer patients, but this does not mean that they should be prescribed first line for these patients. And this is a message to get across to our colleagues and oncologists, because unfortunately, till this day, they think that by prescribing an injection of a GnRH agonist, they have done their job in fertility preservation. Our gold standard, what we use the most in fertility preservation, is conventional controlled overt stimulation with embryo and or oocyte cryopreservation. And when we offer this, we're using the antagonist protocol most of the time because this protocol is quite easy, is reproducible, and is proven. Now, we've had to adapt this protocol for two problems that come with oncofertility. The first is the high estradiol levels that are reached during ovarian stimulation, and that could be problematic in patients who have estrogen-sensitive cancers, such as breast cancers. The solution to that problem was given to us by Dr. Abitayeh from New York 15 years ago with the letrozole protocol. As you all know, letrozole is a third-generation aromatase inhibitor that will block the conversion of testosterone to estradiol in the follicular cells. So with the letrozole protocol, we can stimulate our patients and still have low estrogen levels. Ever since it was described by Abitayeh, it has been used in hundreds of studies, and today it is the gold standard for fertility preservation in estrogen-sensitive tumors. Now, in the early studies, there was some concern about the oocyte maturity in the letrozole protocol. One of the theories was that maybe the high androgen level in the follicular fluid would alter the oocyte maturity, the same that we see in PCOS patients. Now, the first solution that was given by Abitayeh was to wait before we trigger our patient, and instead of triggering at 18 millimeters, that we trigger at 20 or 21 millimeters. That was proven to be efficient in some studies, but others didn't find that impact. The solution to that problem was given to us recently with the GnRH agonist triggering. Now, for those of you who watched this the webinar a couple of weeks ago, my colleague, Dr. Abitayeh, gave an excellent review about the use of agonist triggering. And we know that if in oncofertility, it is the gold standard because you do not want to hyperstimulate these cancer patients who are already fragile. Now, when researchers started using the agonist triggering in letrozole protocol, they started realizing that they had more mature oocytes, higher fertilization rates, and more embryos and oocytes cryopreserved. And that seems to be the consequence of the endogenous FSH and LH surge in the follicular fluid that would counteract the negative impact of letrozole. So today, when you're using letrozole protocol, it is recommended that you trigger the patient with a GnRH agonist. First of all, because it's safer than ACG, no risk of OHSS. Second, it seems to be more efficient in these patients. However, you should watch out because, as Dr. Abitayeh explained, some patients don't respond to a GnRH agonist. For instance, young patients who have long been using the contraceptive pill or thin hypo patients. These patients should be screened because they could use a bit of ACG, but always you should use a GnRH agonist triggering when using letrozole protocol. The second problem we had to deal with was the timing. You know, usually in conventional stimulation, you start the stimulation with the menses and you need 12 to 14 days. But in cancer patients, if she is referred in the luteal phase, you really can't wait 10 days before starting the stimulation. And the answer to that was found in the ovarian physiology and the multiple follicular recruitment theory. We now know that in one menstrual cycle, there isn't one, there are 2 and even 3 follicular waves. So at any point during the cycle, you can stimulate your patient and you will have follicles growing. And this is behind what we use today, and they're called the random start protocols. They were first described by Michael von Wolf from the FertiProtect network in Germany in 2009. So these random start protocols can be broken down into 3 simple scenarios. If the patient is referred in the early follicular phase, well, you start the stimulation immediately. And you trigger when the follicles reach 18 millimeters. Of course, you start the antagonist at 14 millimeters. Now, if your patient is in the pre-ovulatory stage, she has a dominant follicle that's more than 14 millimeters, where the solution to that is you trigger with a GnRH agonist and you start the stimulation 2 days later. And the third scenario is the patient is in the luteal phase, she has a corpus luteum. Well, in that case, you start the stimulation immediately the day you see her. Now, in the luteal phase protocols, there are many variations, and today there is any consensus. Some will start the antagonist immediately. Others will wait till the 14 millimeters before they start their antagonists. And some will use antagonists for 3 or 4 days to induce luteolysis before starting the stimulation. Anyhow, these protocols are nowadays frequently used, and all these variations have given more or less the same results. Random start protocols are nowadays very useful in oncofertility preservation. They have helped us a lot, and they have helped us in developing what we call the dual stimulation protocols. This is also now commonly used in oncofertility patients. It's also used in poor responders, but this is another topic. So for dual stimulation, whenever you see your patient, you start immediately, as we have seen in the 3 scenarios. You trigger your patient, 2 days later you do the retrieval, and 5 days later you start a second stimulation. This will allow you to have 2 stimulations in 1 month, and thus increasing the numbers of oocytes and embryos for that patient and significantly improving her chances of live birth later on. Again, there are lots of variations here. Two things that we should watch out for. First, it's always better to trigger with an agonist because that will hasten the luteolysis and make the second stimulation easier. And whenever you have follicles 12 millimeters and lower, you shouldn't puncture them in the first retrieval because these follicles will grow into dominant follicles in the second one. Now, for dual stimulation to work, there's a sine qua non condition, and that is that the patients be referred as soon as the diagnosis is made. As you can see here, if they are referred the moment that the oncologist sees them, we have the time to do the dual stimulation and increase their chances. You can see in the literature nowadays, lots of studies showing the outcomes of these patients. As you can see here, it significantly increases the number of oocytes, almost doubles it, lots of embryos. The most important thing for oncologists is that it does not delay the treatment. We will only do a dual stimulation if we have the time. We will not defer the chemotherapy just to do a second cycle. And we're starting to see data about the safety of these protocols, small data from small studies, but reassuring so far. Now, what about the efficiency of these protocols? We've seen them all, they work. Now we're starting to see large series coming oncofertility from big oncofertility centers worldwide. You can see the live birth rate between 20 and 45, 50%, which is really good. Now, there are some concerns during the stimulation that cancer patients respond poorly to stimulation and that their live birth rate could be lower. If you take this report from the EV group that was published a couple of years ago, they saw that they compared oncofertility outcomes to social fertility outcomes. And they saw that in patients younger than 35 years of age, the live birth rate was significantly lower in cancer patients. In the age group above 35, there wasn't any difference. So this is a question mark that remains to be answered. And I think in the next couple of years, we will be seeing more and more series about live birth, and we'll be able to answer that question. And these protocols, and it's very important to tell that to our oncologists, these protocols are quite safe. Now we have lots of data coming from not randomized trials, from retrospective cohort studies, from systematic reviews about the patients who had fertility preservation. There is no change in the disease-free survival or in the survival of these patients. This just came out in Human Reproduction. This is the largest multi-center series so far coming from Sweden, where they compared all patients who had cancer, whether they had stimulation or not, whether they had letrozole or not. They didn't see any difference in their survival or disease-free survival. So this is to reassure our oncologists and our patients that what we're doing does not harm them. A quick word about it's the special case of neoadjuvant chemotherapy. As you know, nowadays, more and more patients are being treated with neoadjuvant chemotherapy for breast cancer in order to reduce the size of the tumor and be able to do a conservative surgery. And oncologists have a problem with that. I mean, how could you stimulate a patient with the tumor still in situ? Well, now we're seeing lots of data coming out about, again, small series, but they show that when you stimulate these patients, first of all, it does not delay the chemotherapy, and it leads to a competent oocytes and embryos without altering their long-term survival. Now, again, these are very preliminary data, but I think when we have these patients, we can stimulate them, especially that we know that they can start the chemotherapy the day we retrieve the oocytes. Now, a word about a new protocol that we're seeing for oncofertility, and it's the progesterone-primed ovarian stimulation. You know, we've known for quite a while that progesterone can block the LH surge in natural cycle. But what we know now is that it can do so in a stimulated cycle. This first came out in China in 2015 by Kwang and colleagues, where they used oral medroxyprogesterone acetate to block their patients who were stimulated in the luteal phase. And they saw that the results were comparable to the antagonist protocol. And since that study, there have been at least 12 RCTs on the subject, and they have used quite different variations, whether it's MPA 10 milligrams, 4 milligrams. They also use etradiol 200 and 100 milligrams. And recently they used the difaston 10 milligrams per day. And all these studies have shown the same. They are quite comparable between them, and they are comparable with the antagonist protocol. Why is this important? Because first of all, these protocols are patient-friendly. You are removing at least one injection for these patients per day. Second, they are much cheaper. You know that cost is a problem in oncofertility patients because they are not covered. So the oral progesterone is way cheaper than the daily antagonist. The only thing is that the live birth rate and the health of babies are still to be published. We have some data, some reports coming on, but we don't have large series so far. I believe this protocol is very interesting for oncofertility patients, and I think we'll be seeing lots of series coming out in the next couple of years about that protocol. So in conclusion about this protocol, the controlled ovarian stimulation, it's really our gold standard. It is quite efficient, it's quite safe, and as you have seen, it is adaptable to the needs of our patients, and it is reproducible. Any IVF center can do these protocols and improve the pregnancy chances of their patients. Now for the second technique we have, and this is ovarian tissue cryopreservation and transplantation. I recently read that the first case of transplantation goes back to 1906 with a surgeon in New York transplanted a fresh ovary into a uterus, and the patient had her periods 4 months later. Today, oocyte tissue cryopreservation is a very important technique, especially in oncofertility. It's quite unique because it is the only technique that we can offer to prepubescent girls. It does not require any hormonal stimulation, so it can be done immediately as soon as the patient is referred. It's the only technique that allows to preserve not only fertility, but also the endocrine function of the ovaries. It allows us to store thousands of follicles, not just hundreds, or even 10 or 15 like we do in a stimulation cycle. And most importantly, patients can get pregnant on their own without any IVF. Now, you know the three steps for oocyte tissue. So we harvest the either half the ovary or the third or even the entire ovary, obviously depending on the patient's age and cancer. Cryopreservation, small fragments. Until now, most centers have used slow freezing, but many centers are switching toward vitrification, and then transplantation can be done when the patient is cured from her cancer. Now, there's lots of debate in all oncofertility and even in all fertility congresses about whether ovarian tissue cryopreservation should be considered experimental, innovative, or an established technique. And I think to answer that question, you have to look at these 4 criteria. The efficacy, which is the technique doable in the best case scenario in very good labs, its safety, whether it's reproducible, and its effectiveness, which is the performance of the technique in everyday scenario. And if you take, for example, the example of prepubescent girls, well, in these girls, the efficacy is not proven. There's only just 1, I think 2 live births reported in girls who had the ovarian tissue preserved before the puberty. We don't know anything about the safety or the effectiveness of the procedure. So for these girls, it is considered experimental. Now, if you take adult women who have cancers with a high risk of ovarian metastases, for instance, leukemia or a Burkitt lymphoma, in these women, the efficacy is yet to be established. There are several reports about live birth in these patients, but we don't know anything about the long-term safety when retransplanting the ovarian tissue. The procedure is quite different between centers, and it is not reproducible in all IVF units. So for these patients as well, it is considered experimental. But if you take the example of adult women with cancers that are very unlikely to metastasize to the ovaries, such as early stage breast cancer or Hodgkin lymphoma, well, in these patients, the efficacy is proven. There are more than 130 live births in the literature. The midterm and long-term safety data are very good. The procedure has been performed all over the world by many centers. So in these patients, ovarian tissue cryopreservation is an established technique. In the last couple of years, several authorities and several societies have changed the tag of ovarian tissue. The latest was ASRM last year, and they went from considering it experimental to considering it an established procedure with limited effectiveness that should be offered only to carefully selected patients and in centers with enough experience. Now we're having more and more data about the efficiency of that technique. As you can see in the biggest series coming from the biggest oncofertility centers, the live birth rate are between 20, 30%, even 40% in some series. Now, we are seeing more and more data about the transplantation of ovarian tissue in women whose tissue was preserved following chemotherapy. This is what they usually do nowadays for patients with leukemia because of the high risk of ovarian metastasis. Again, the live birth rate in these patients are quite good, 32%. But again, this is very early data, and this is only in a research setting. Now, in oncofertility centers, what we're doing is the combination of many techniques in order to improve the efficiency. And you'll see many papers nowadays about the combination of ovarian tissue, ovarian stimulation, and IVM. I have talked about IVM because I don't think anyone is offering it in Lebanon. I don't know about our colleagues in the Arab countries. Usually in IVM, you get to retrieve immature oocytes and mature them in vitro to the metaphase 2 stage. So now you can offer all these techniques together. You stimulate your patient, you get mature oocytes, and you take out the ovary and you take immature oocytes from the ovary. Usually the ovary is taken before the stimulation because studies have shown that if you stimulate the patient, it will affect the quality of your tissue. And I'm gonna finish with a word about the current research in oncofertility. There are mainly three directions. The first is the development of new molecules that will protect the primordial follicles, such as phangosine 1-phosphate, even some gene therapy. The second direction, which is the most promising, is to improve the graft. The problem with ovarian transplantation is 2/3 of the follicles are lost when you transplant. So they are developing some matrices and also lots of factors to improve that grafting. And finally, the development of artificial ovaries and the in vitro culture of primordial follicles is in the very, very early stages nowadays. So to conclude, fertility preservation is a must. It is a part of cancer treatment today. Fertility preservation with ovarian stimulation is the method of choice. It is feasible, it is safe, and can be associated with ovarian tissue cryopreservation. Thank you for your time.
Thank you so much, Dr. Hachem. It was an excellent presentation. We will move to the other presentation. The fertility preservation in women with endometriosis, is it for all, for some, or for none? Dr. Houssam Abdel Reda, who is an OBGYN AUB graduated, who did his fellowship in reproductive endocrinology and infertility at the King's College at London. He works actually now at the Clemenceau Medical Center, and he will talk about the fertility preservation in women with endometriosis. Thank you, Dr. Houssam.
Hello, good evening. Can you hear me all? Can I start?
Yes, please.
Yeah, hello, good evening. I'm really honored to be here today and to participate in this successful series of webinar. So today I will be discussing fertility preservation in women with endometriosis. I know that endometriosis to many of us is still and remains an enigma to every practicing gynecologist. And even there is books written about endometriosis and its complexity, and especially in the management of endometriosis. So luckily today, I will not discuss the complicated management of endometriosis. I'll only approach the topic of fertility preservation endometriosis. And due to the limited, as we'll see, to the limited available data on fertility preservation endometriosis, let's consider this presentation as an eye-opener to fertility preservation and endometriosis. And the main objective of this presentation is to try to answer a couple of questions, mainly three questions. Let me ask you all, and if you are seeing today a patient in your clinic, she's a 31-year-old lady, single, presenting for chronic pelvic pain. She had a laparoscopy and it showed mild endometriosis. Her AMH is low and she had a low AFC. Would you offer her fertility preservation? The second case, she's the same lady, she's 31, but this time she's diagnosed with bilateral endometrioma, 5 and 3 centimeter bilateral endometrioma. And she's planned to have a laparoscopy and cystectomy the next month. Would you offer her fertility preservation or not? The same case scenario, a 31-year-old lady presenting with chronic pelvic pain. She already had a laparoscopic cystectomy for right endometrioma 3 years ago, and now she's having a recurrent 4 centimeter left endometrioma, and is planned to have a surgery next month for chronic pelvic pain. Would you offer her fertility preservation or not? So to try to answer these questions, well, let's go through and review some facts. First, as we'll see, as Dr. Abitayeh discussed previously, and we'll see later with Dr. Azoury, we all agreed now that our society has undergone significant changes, and women are delaying their childbearing plan. They are pursuing higher education, advanced education, and career advancement, and therefore they are delaying their childbearing plan. And now, women are becoming moms for the first time later and later in their life. And the history of the royal British family It's a good example to review. When Meghan Merkel gave birth to her first baby, she was 38 years old. Compared to Kate Middleton. Kate Middleton was 31 years old lady. She was 8 years younger than Meghan Merkel. And if you think that Kate was young at that time, you should see Prince Diane. She was 21 years old lady when she gave birth to her first baby. So there was a decade less than Kate Middleton. So it's a fact that women are becoming moms for the first time later and in their life. And in Greece, for example, is the number one. It's Greece, and Lebanon is now ranking is 79. It's ranking probably with our economic situation. Hopefully, will not be number one if we are following the steps of Greece. And it's not also different for fathers also, because also the average age of parenthood for men is also increasing compared to what it was before. So nowadays in 2015 it was 33.3 compared to 24.2 years when in 1975. So with all the celebrities we see in the media getting pregnant in their 40s or their 50s, we do think that we have all the time in the world to get pregnant, so we can delay all our plans. But the problem is with increasing age and with delaying childbearing, you see the lot of medical problem, the prevalence of a lot of medical problem, including obesity, will start to increasing with age. And with obesity will come a couple of comorbidities like hypertension, diabetes, and therefore we'll have a higher risk of obstetrical complication, including miscarriages, preterm labor. So if you want to look at the higher scale level and the population scale level, you can see that nowadays the population is becoming older, and we have an older population, a fatter population, and a sicker population coming for fertility preservation and for IVF treatment, and they are trying to couple to become pregnant, and that will pose a lot of additional major issues for fertility treatment. Therefore, nowadays, if you have a look worldwide, you will see that the fertility rate is starting to decrease, and it's a reality compared to what it was before. So we have a decrease in the fertility rate, and definitely this will lead us that soon scientists and politicians will stop talking about the famous pyramid of age, and will start talking about the dawn of age instead of the pyramid of age, because the structure of the society will start to change. Of decades will start to change, because you will see less people, young people will have, the population will become more and more age. And therefore, offering fertility preservation is becoming a must, and especially educating patients about fertility preservation and the possibility that it might lose their fertility potential in the future, because sometimes general population are misled by figures like Janet Jackson getting pregnant at the age of 50. And therefore, the general population, usually they think that we as an IVF specialist, we can do magic, where they can get pregnant at any time. They can come at 43, 44, they can try a fresh cycle in IVF, and therefore we can do magic for them and they can get pregnant so easily. But we as the fertility specialist, we know this is a serious issue. And therefore, in Europe nowadays, and especially in Europe, in UK, they are considering seriously to include fertility education and to implement fertility education as part of their school curriculum, to educate young population about the possibility of losing their fertility potentials. And nowadays, with the use of fertility preservation technique, and especially with the oocyte vitrification, I was about to present a few slides about fertility, about vitrification or oocyte vitrification, but I do think that Dr. Azoury will discuss it more in detail. That's for I will move forward. Just I was about to showing you that fertility, that the oocyte vitrification is an effective technique and should be offered, and it's not anymore an experimental technique. And we as a fertility specialist, we should not refrain from offering fertility preservation for our patients, especially oocyte freezing. We should, on the contrary, we should encourage people, ladies, to have fertility preservation. And if they are going to have fertility preservation, it's our role to make it done properly, to offer people more than one cycle, and to increase their chances of getting or being successful with their fertility preservation, and to have more egg, therefore will increase their chances of getting pregnant in the future. And thus will lead us to our fertility preservation topic in endometriosis. With this increasing level of confidence in fertility preservation, with oocyte vitrification, with ovarian tissue freezing, therefore, nowadays we are trying to expand the potential use of fertility preservation. Nowadays we are trying to expand to offer fertility preservation to every medical condition, whether it was benign or heterogenic medical condition that might affect the fertility potential in the future. We are offering fertility preservation to those patients, and therefore patients with endometriosis are particularly a suitable group to offer them fertility preservation, because endometriosis is very well known to be associated with increased risk of infertility and impaired ovarian reserve in the future. And it's a chronic disease that might recur with a 20% risk of recurrence in the future. And so we'll have to deal with it again in the future. That's why many authors advocated using fertility preservation in endometriosis, and that's why we started to talk about it like 10 years ago. But what we have to know that endometriosis, it's a common disorder. It might affect up to 20% of women of reproductive age, and might affect 30 to 50% of infertile women. And this infertile woman might have up to a chance up to 40% of being diagnosed with endometrioma at a certain point in their life. And 50% of affected women will fail to achieve a natural pregnancy and might require IVF at a certain point in their life. But the relationship between endometriosis is a little bit complicated because it's a complex interaction. Endometriosis per se as a disorder might affect the fertility potential and might decrease the ovarian reserve without having without doing any further surgery. And the surgical treatment of endometriosis is an additional risk factor that would damage and worsen the ovarian reserve. And if you want to discuss the effect of endometriosis and fertility, you should discuss it specifically for endometrioma, because ovarian endometriomas are of particular concern, because endometriomas are associated with detrimental effect that could be due to the high toxicity and the high concentration of potential toxic agents like the free iron present in the endometrioma. And also it could be the result of mechanical long-lasting stretching effect from the endometrioma on the adjacent ovarian cortex, including containing the remaining pool of primordial follicle. And many histological studies have confirmed and showed a significant reduction of the pool of primordial follicle in the ovarian cortex of around the endometrioma even before surgery. But the clinical evidence is still weak and still a little bit conflicting, despite that it has been shown that there will be less ovulation from the affected ovary, from the endometrioma of the affected ovary, and ovarian response to controlled ovarian stimulation may be decreased in ovaries with endometrioma, and fewer oocyte could be collected even after controlled ovarian stimulation in patients with endometrioma, and serum AMH may be decreased in patients with unilateral and for sure with patients with bilateral endometrioma. And the main reason for this conflicting clinical data, it comes from the nature and from the type of the published studies, because the majority of the published study including endometrioma of small size, less than 2 centimeters. That's why it's almost difficult to generalize the data to all the population, and especially that the endometriomas were less than 2 centimeters. And now, what about the surgery? We all know that the classical method of ovarian surgery for endometrioma was the classical ovarian stripping, where we remove the cyst wall, the ovarian cyst at the wall, and we try to strip out of the adjacent ovarian cortex. And the vast majority of studies analyzing the effect of stripping on the ovarian reserve had showed that ovarian stripping is associated with an increased risk of damaging the ovarian reserve and decreasing the ovarian reserve and decreasing the remaining pool of primordial follicle and in the remaining ovary. And this was very well documented, despite that the recent meta-analysis didn't show any difference of intrafollicular count between before and after surgery, but that was followed by a couple of papers, especially review articles and meta-analysis, the one by Rafi and the one by Somigliana, showing the paper of Somigliana showed definitely a decreased anti-Mullerian hormone after surgery for endometrioma, and a decreased ovarian reserve after endometrioma, and this was statistically significant. The paper of Rafi here, they showed classically that the ovarian reserve will that there will be a difference in the ovarian reserve before and after surgery. And also a couple of studies showed that ovarian reserve could be severely compromised, and even it could lead to premature ovarian failure in 10 to 15 of patients operated for ovarian endometrioma. And the response to controlled ovarian stimulation, it was clearly identified that patient operated for endometrioma will have a lower number of eggs collected and lower number of vitrified oocyte available for vitrification and fertility preservation after surgery, and even the number might be decreased by a half after ovarian surgery for endometrioma. And also, patient operated for endometriosis for endometrioma might enter a menopause earlier than expected, and they will always have a low but consistent risk of post-surgery decreased ovarian reserve of even for a long period of time. And the cause for this decreased ovarian reserve and for this damage to the ovarian reserve, it could be a mechanical one resulting from the stripping and from trying to pull the ovarian cyst wall and therefore removing adjacent healthy ovarian tissue or around with the ovarian sac, or it could be a thermal or vascular damage resulting from the use of electrocoagulation in our when we try to anesthetise and try to control any sort of bleeding after the surgery. Therefore, different surgical approach such as the use of a laparotomic approach instead of a laparoscopic one, especially for non-experienced surgeon, the use of surgical suture approach rather than to control hemostasis rather than electrocoagulation, or just to drain the cyst, and the use of laser vaporization of the cyst wall, or a combination of both. This technique might be less detrimental, but still evidence is still weak, and we're still waiting for more evidence to recommend any sort of different surgical approach. In view of this complexity of surgical management of endometriosis and in the presence of more than 150 recommendations available to guide us for the management of endometriosis, therefore, I will not go into further detail and will leave the management until for a future presentation. So now after we all reach an agreement and a general consensus that ovarian endometrioma might affect our ovarian reserve, and doing surgical management and surgery might significantly worsen this damage. Therefore, maybe it's of paramount importance, and it's not, after all, a bad idea, or maybe it's very rational to offer fertility preservation for patients with endometriosis. But the question here remains, should we offer fertility preservation to all the patients with endometriosis, or we have to be selective? To answer this question, let's have a look at the literature available. The literature, as I told you previously, is a little bit limited because there is a limited number of publications. If you do search yourself, you'll see that there is only 2 case reports discussing fertility preservation endometriosis, 1 basic science study, 5 retrospective cohort study, and 1 review article. So far, there is no randomized controlled trial or prospective study design. The first case report was published in 2009 by Elizur, where they reported a 25-year-old lady presenting with endometriosis with previously 4 surgeries for endometriosis. She underwent 3 cycles of controlled ovarian stimulation, and they managed to cryopreserve 21 oocytes for that lady, but there is no data on the later outcome. The second study was the prospective study by the group of Velasco. Here, they included 38 women with endometriosis coming for fertility preservation. 5 patients returned and thawed their oocyte, but unfortunately, we don't have any follow-up data on the outcome or the live birth rate in these ladies. In 2017, Rad et al. Published a study. This was also a observational study, and the total number of patients included was 49 patients. Patients were divided into 3 groups according to their endometriosis phenotype and stage. First group was people who was patients with superficial endometriosis, second group with endometrioma, the third group with deep infiltrating endometriosis. There was no significant difference between the 3 groups of patients, but eventually they showed that there was a significant decrease in the number of oocyte and the number of M2 oocyte and the number of vitrified oocyte in the group of patients who had a previous surgery. So patients with previous surgery for endometrioma had a decreased number of oocyte collected. That leads us to the study of Bobo et al. This is the largest observational study done. It was published recently, and it was a multi-center study, descriptive observational study. And here they included a total number of 485 patients with endometriosis. And the main outcome of this study was oocyte survival rate and also originally the cumulative live birth rate. So they reported the live birth rate after fertility preservation. The secondary outcome in this study were the number of retrieved oocyte and vitrified oocytes, the embryo quality, and the clinical and ongoing pregnancy rate. And both primary and secondary outcome were compared based first on the stage on the endometriosis, was it stage 1 to 2 or 3 or 4, and on the surgical status of the patient, whether they had undergone surgical treatment for endometriosis or not. Let's have a look at the data. The baseline characteristics showed that 97.7% of patients had stage 3 to stage 4 endometriosis, and only 3% had stage 1 to 2 endometriosis. So the vast majority of the patients had advanced stage endometriosis. And also surprisingly, 47.8% came for fertility preservation after surgery, not before. So almost half of the patients had surgery done before for endometrioma. The survival rate was good, was 83.2, and was comparable to the general population. And surprisingly for this study, that the return rate was 46.5. And that means that 46, that almost half of the patient returned to use their vitrified oocyte, and this was only within a period, within a window of 1.1 year and 7 months only, and that was a little bit strange for patients to come back to use their fertilified oocyte after 1 year or 1 year and a half, despite that we know that people don't return to use their fertilified oocyte, whether it was done for cancer treatment or for social egg freezing, until after a couple of years. The main result here showed that there was no difference as previously reported in the outcome based on the stage of endometriosis. So patient with stage 3, stage 4 didn't do differently than patient with stage 1 or stage 2, despite that almost only 3% of the patient were diagnosed with stage 1 or stage 2 endometriosis, but there was definitely, as expected, a difference based on the age. Patient less than 35 years of age did much better and had a higher number of oocyte collected or vitrified oocyte, and definitely had a higher chance of pregnancy, of clinical pregnancy rate, of cumulative live birth rate up to 61% compared to 28% of patient of live birth in patient more than 35 years of old. Here, they tried to compare the group of patients who had surgery and the group of patients who didn't have surgery. What they found is patients who had surgery were a little bit younger. So patients who had bilateral surgery were younger than patients who had unilateral and no surgery. Patients who had bilateral surgery were younger, were 33.4 years old compared to 36 for patients who had any surgery. And for sure, a patient who didn't have any surgery had a higher number of oocyte collected, of vitrified oocyte, and of M2 oocyte vitrified. And this was a little bit expected, to have a higher number before surgery and to have a lower number of oocyte collected after surgery. But what was surprising in this study, that the clinical live birth rate was the same between the three groups, between the group of no surgery or unilateral surgery or bilateral surgery. So surprisingly, patient with bilateral surgery had a comparable live birth rate, 49.3%, compared to patient who hadn't had any surgeries previously, despite that you would expect the opposite. But the main explanation for this is that people who had surgery were a little bit younger to the group of patients who didn't have any surgeries, and that might explain the difference in the clinical pregnancy rate. That's why they did a more complicated analysis, a multivariate analysis, where they analyzed the data based on age in patient less than 35 and patient more than 35, and based on whether they had surgeries or not. In patient less than 35 years of old, the group of patients with no surgery did much better, and they had a higher number of oocyte collected, higher number of oocyte vitrified, and the clinical pregnancy rate was higher, was 72.5 compared to 52.8 in patient who had surgery. But this wasn't the case for the patient, for the older group of patients. So in patient 35 years of old, there wasn't any difference whether they had surgeries or didn't have surgeries before, because the clinical pregnancy rate was similar. But also that might be due that the group of patients who had surgery were a little bit younger than the group of patients that didn't have surgery, and maybe that's the main reason why we are also having the same clinical pregnancy rate. Then they compared the group of patients with endometriosis with a control group of patients coming for social egg freezing or maybe for fertility preservation. In patients less than 35, there was a difference between the group of patients with endometriosis compared to the group of patients with elective fertility preservation, because patients coming for fertility preservation did better, much better than the group of patients with endometriosis, but wasn't the case again for patients more than 35. For some reason, older patient more than 35, age more than 35, they are doing they are doing almost the same as the control, whether with patient with endometriosis or patient who didn't have any surgery. So that's why mainly in this study they concluded that offering surgery for endometrioma in patient more than 35, it would not make any difference whether we do it before or after fertility preservation. But the group of patients less than 35, maybe it's more wise and it's more recommended to offer fertility preservation before having surgery for endometriosis, despite that doesn't make sense anymore, because younger patients are supposed to have a better ovarian reserve and they are supposed to do a much better after surgery, and the higher they have, the higher the ovarian reserve, so before surgery, so the higher will be after surgery. And in this study, a total of 219 patients failed to become pregnant after using all fertilified oocytes, so they had to go with a fresh cycle. 26.6 had a fresh cycle, and the clinical pregnancy rate was 41.4%. So as you can see, the clinical data are very limited, and there is no clear recommendation when to offer fertility preservation to what group of patients, and there is no clear algorithm to follow. So what to do about it? And the success rate, as you see, is mainly extrapolated from different category of patient, for patient coming for social egg freezing, or from the group of patient coming for egg donation. And for patient for endometriosis, there are still some concern over the number and quality of oocyte that can be retrieved and remaining pool of primordial follicle. That's why advocating systematic fertility preservation to every endometriosis patient is a little bit premature, because that's how we'll be offering fertility preservation to almost 10 to 20% of patients, and this doesn't make any sense. That's why we have to be more selective, and we have to take into consideration a couple of factors, like we have to see the age of the patient, if she's young or she's old, her current ovarian reserve, the disease extent, and the history of previous surgery, and the progression rate and of the disease, and whether she needs further surgery or not. And in a nicely written review, Somigliani tried to discuss the pros and cons of having fertility preservation of endometriosis, where they tried they try to divide patient in different group, and in this different group, based on the assumption that the fertility preservation could be beneficial, and it's proven efficacy. Therefore, they divided patient in different group, and based on the quality of fertility preservation available, whether patient will come back or use their fertilified oocyte, and what's the likelihood that the frozen eggs will be used, and what the chances of what the risk for the patient of losing their fertility potential. And in conclusion, they concluded that patients with bilateral endometrioma will benefit the most from fertility preservation, and the patient who had previous monolateral excision of endometrioma and they're coming for contralateral recurrence, and patients with previous surgery for bilateral endometrioma with no endometrioma recurrence. So basically, in conclusion, if we want to cut a long story short, patient with bilateral endometrioma and patient with a natural endometrioma and coming back for recurrence, and patient who had previous surgery for endometrioma and coming from recurrence will be the group of patients will benefit the most from fertility preservation. In conclusion, to sum it a little bit up, now we know for sure that decreased ovarian reserve in severe endometriosis is now widely recognized, and it's widely recognized, and we have to deal with the fact surgery, whether bilateral and repeated surgery, are associated with additional reduction of follicular reserve and further damage to the ovarian reserve. Therefore, offering personalized reproductive counseling should be an integral part of the endometriosis management. And the evaluation should be a comprehensive one. It should take into consideration multiple other factors. And more studies are needed, especially pilot studies are needed to guide us and to provide us with clear algorithm and guidelines when to offer fertility preservation. And the main question that need to be answered is how can we predict future fertility or infertility in women with endometriosis? Therefore, we'll be able to identify women at higher risk of losing their fertility preservation because of having endometriosis, and therefore will be able to offer fertility preservation endometriosis to a selective group of patients. Therefore, here the procedure will be much more cost effective. And advising people to a patient to get pregnant at early age is recommended, and please try to avoid surgery whenever it's possible to do so and to avoid surgery. And fertility preservation is of interest for patients with bilateral endometrioma.
Early age. Unfortunately, we're running out of time.
Well, I'm finishing. This is my last slide. Thank you, Layal. Thank you, dear. So to answer the question whether to offer fertility preservation or not, so for this 31-year-old lady with the history of mild endometriosis and decreased ovarian reserve, maybe it's better to offer her fertility preservation, especially that she has a lower AMH and a lower AFC. For the second patient with a bilateral endometrioma, also the answer is yes, it's better to offer her fertility preservation. And for the last patient with the history of endometrioma and coming for a recurrence, also it's best to offer her fertility preservation. Thank you, Layal, and that's the end of my presentation. Thank you all for attending.
For this presentation. After covering the most frequent medical cases of fertility preservation, we will move to the social fertilization preservation with Dr. Azoury. Dr. Azoury is a very well-known doctor. He's the pioneer of IVF in Beirut, in Lebanon. He has 30 years of experience. He is the founder and the head of infertility department in Mount Lebanon Hospital, and he was the president of the Lebanese Fertility Society from 2017-2019. He will develop the most trendy subject about fertility, social fertility preservation. Thank you, Dr. Azoury. La parole est à vous.
Well, hello everyone. Thank you, Layal, for presenting me. First of all, I want to congratulate the Lebanese Fertility Society for all the successful scientific webinars they are doing. And I want to thank the Society and Merck for inviting me today. I will be discussing social fertility preservation, which is also known as social egg freezing.
Please, can we go out of the screen of Dr. Houssam?
Can we show our, yes, please, Layal.
Jesse? Yes.
Yeah.
Perfect.
Okay.
Great.
Let's go. Okay, we're fine.
Well, in fact, these days, and like Dr. Houssam has nicely showed us, we are observing a social trend toward delaying childbearing in women of reproductive age. Social egg freezing means to preserve and store oocytes for non-medical reasons to healthy fertile women who wish to postpone motherhood for various reasons, such as educational or career demands, or because they had not yet found a partner. In your opinion, is social fertility preservation is just a trend, or a woman's right ensuring gender equality, or preventive medicine? Please place your votes. There is no correct answer for this. Please, I'm waiting for your vote, please.
Please vote.
Okay, let's move on.
Okay, Zong, I think there is no correct answer for this question. We are waiting for your vote. In fact, 43 they are voting for a women's right ensuring gender equality, and 57% for preventive medicine. Thank you. In fact, this question is very important in other countries where fertility treatment in general is covered by the government and the insurance, because answering this question will determine if egg freezing should be covered as well as if subsequent IVF cycle should be covered. Sadly, in our countries where basic medical treatment face the risk of not to being covered anymore, answering this question will not have any importance, at least for the coming decade. What is the main goal? It is the prevention of age-related infertility that motivates women to store their gamete. In this paper published in 2014, Stoop and al. Argue that the commonly used phrases social and non-medical freezing are not entirely correct. They suggest using the terms age banking, as this shows the exact indication for the strategy, which is banking for anticipated gamete exhaustion caused by age. Is it a safe procedure? The development of oocyte vitrification techniques has significantly improved the oocyte survival rate and clinical pregnancy rates when compared to traditional freeze-thaw techniques. It has also been demonstrating that there is now no difference in pregnancy, miscarriage, or live birth rates between autologous fresh and cryopreserved oocyte cycle. What are the risks? The most important medical risk associated with freezing is ovarian hyperstimulation syndrome. However, with agonist trigger in an antagonist protocol system, hyperstimulation can be completely avoided. The risk of oocyte pickup procedure are nearly null. It is proposed that there is an important risk of giving the patient false promises and false hope, a risk that women with cryopreserved eggs will delay reproductive life counting on these eggs. And finally, there are the risks related to pregnancy at an advanced age that are known by everyone. This paper, published in 2015 in Human Reproduction, showed that freezing oocytes does not appear to influence the life choices of the woman that behave exactly like women who does not have frozen eggs. It has, however, shown that there is an important psychological aspect of reassurance associated with preventive oocyte banking, expressed by high satisfaction after banking. The remaining risk related to social fertility preservation as false hope and false promises can be avoided if proper counseling is ensured. Physicians should provide extensive counseling before egg freezing to discuss financial, ethical, and societal implications, as well as the medical risk and the possibilities of future and successful treatment. Medical assessment and counseling is also required before the utilization of eggs to assess the risk of age-related obstetrical complications. In order to provide good counseling, the physician has to know the real chances, and in clinical practice, he should be able to answer questions regarding the number of cryopreserved oocytes sufficient to achieve a live birth and whether or not additional stimulation cycles are likely to result in a real increase in the chances of live birth. The study was performed by the Fox team in Harvard and published in Human Reproduction in 2017. It presents a model that predicts the chances of live birth for social freezing, and that could serve as a nice counseling tool for physician and patient. The data was retrieved from 520 women with normal ovarian reserve. This included couples diagnosed exclusively with male factor and or tubal factor infertility. Age-specific probability of euploidy were estimated from 14,500 PGS embryo results. They assumed survival of those oocytes at 95% for women less than 36 years and 85% for women more than 36 years. Live birth rate per transfer of euploid blastocysts was assumed at 60%. The predictive model that was developed shows the number of mature oocytes needed to reach a live birth according to the woman's age at the time of freezing. If we take, for example, a woman which is less than 35 years old, we can see that 10 frozen eggs give her a probability of 70% to achieve a live birth, while 10 frozen eggs give less than 10% probability of live birth for a woman at 44 years old. Hence, age banking should ideally be performed on women who are less than 35 years of age, as in this case, only 1 or 2 stimulation cycles would be required to obtain the needed number of oocytes. But in reality, it is mostly performed after the age of 35, and when performed in the late 30s, the number of oocytes of cycle needed is not very realistic, as the number of eggs obtained by stimulation cycle also decreases. This is indeed a helpful tool. However, it's very optimistic. The assumed post-oocyte survival rates, 95% for women under 36 years and 85% for women older than 36 years, are ideal and most probably higher than those observed in other programs. Women included were only suffering from tubal or male factor, while in reality, women suffering from endometriosis or other conditions that might change egg quality can be seeking social fertility preservation. So this model probably overestimates the chance of live birth. The best outcome data to develop a predictive model would be obtained from women who have undergone oocyte cryopreservation with vitrification and then returned to use their oocytes. However, at the present time, there is a few data available. The study published in Fertility Sterility was performed on women who have undergone oocyte vitrification and then returned to use their oocytes. The objective of this study was to estimate the chance of live birth at least 1, 2, or 3 children according to the number of mature oocytes cryopreserved by elective fertility preservation patients. A total of 1,283 vitrified oocytes were worn for 128 autologous IVF treatment cycles. The overall efficiency was 6.4%. Probability of live birth depending on the number of frozen eggs was calculated for each age group. For the group of women between 30 and 34 years, 10 vitrified oocytes were shown to give 60% chance of having at least 1 live birth. 30 oocytes are needed to provide 90% probability of live birth. For the group of women between 35 and 37 years, 10 vitrified oocytes were also shown to give 60% chances of having at least 1 live birth. 30 oocytes are needed to provide 90% probability of live birth. So there is no big difference with the 30-34 age group. For the group of women between 38 and 40 years, 10 vitrified oocytes were shown to give around 40% chance of having at least 1 live birth. 30 oocytes will provide 70% probability of live birth. Finally, for the group of women between 41 and 42 years, 10 vitrified oocytes were shown to give 20% chances of having at least 1 live birth, and 30 oocytes will provide probability, 50% probability of live birth. Another comprehensive study was published in Fertility Sterility in 2016. It included 1,038 women who underwent social egg freezing. 120 returned to use their eggs after a mean duration of 2.2 years. The oocyte survival rate was 85% with subsequent clinical and ongoing pregnancy rate of 39 and 27% respectively. A more recent prospective study evaluating the efficiency of egg vitrification found the proportion of vitrified oocytes resulting in the live birth to be 8.2% in women under 36 years and 3.3% in women between 36 and 39 years. So what are the limitations? As we have seen, social fertility preservation efficiency is mainly related to the age of the woman and the number of eggs retrieved. A personalized approach taking into account the ovarian response and the number of eggs obtained by stimulation cycle is needed to guarantee a good counseling and to help the patient analyze the cost efficiency of each freezing cycle she undergoes. Financial cost of the process is also one of the main limitations and has to be taken into account too. We have seen that the number of eggs required is most of the time not achievable, and we have seen that even 30 eggs in a young patient cannot guarantee a live birth for 100%. So age banking is a matter of hope and never a matter of guarantee. If the patient is looking for hope to feel satisfied, one egg is enough given that she is aware of the real chances. In conclusion, we all know that age has a drastic effect on a woman's fertility, and we know that we are observing a delay in childbearing age, so oocyte banking for age is recommended, and it is a preventive action and can have a possible curative function in the future. Medical risks are quite inexistent. False promises and false hope can be prevented if proper counseling is provided. Limitations are age, ovarian response to stimulation, and cost. Despite the growing number of awareness campaigns, young people are still not aware of natural limits of female fertility and significantly overestimate the success rate of assisted reproductive technologies in helping them to conceive at advanced age. The Lebanese Fertility Society is doing a very good job, and it has to continue creating awareness about the subject. As a result of awareness, we see that the number of elective egg freezing cycles is increasing. In our clinic, we did 10 cycles in 2017 and 32 cycles in 2019, but still these numbers are very low. We have 90% survival rate, but we have very few data of patients who came back to use their eggs, so statistics cannot be performed yet. At the end, the main goal of everything we do is helping women achieve their maternity dream honestly and safely. Thank you for your attention.
Thank you, Dr. Azoury. And now we will move to the question. Maybe it's easier to raise hands to ask directly the question to the person concerned. There is already many questions that we already answered. How many cycles of fertility preservation for cancer patients do our speaker in Lebanon? And what the live birth rate in Lebanon in these cases? I don't know, this question is for her. We have another live question, maybe it's better to take it.
Hi.
Hello, hello, Dr. Abbas.
Hello. We're hearing.
I'm Dr. Salah Mohammed Abbas. You hear me?
Yes, properly.
The Vice President of Iraqi Fertility Society.
You're welcome.
Yes. I want to thank the Lebanese Fertility Society for its invitation for our society members to attend this nice critical topic in this difficult life situations which we live with the pandemic of COVID-19. And we look forward for attending more future scientific events. I want to ask about leukemia. I know it is a difficult subject for fertility preservation, but I want the idea of Dr. Hady for this. And also I want to ask about in breast cancer, is gonadotropin releasing analog? We think it was a good option to reduce the effect of chemotherapy on fertility. Is that fact changed now? And thank you. And I want to say hello to Dr. Azoury and Dr. George. Thank you.
Hi, Dr. Abbas. We are happy that you are with us today. Thank you to be with us.
I'll answer your question. Thank you for your great questions. For the leukemia patients, unfortunately, we all know these are the most difficult cases. Now, most of the cases that are referred are usually AML or ALL. So usually these patients, if they require treatment, the usual treatment is not that gonadotoxic. But the problem is when they're referred for a relapse and they require a hematopoietic transplantation, these patients have a 70 to 100% risk of ovarian failure. And the problem is when they're referred, they already are anemic and have low platelets. So ovarian tissue is difficult. Stimulation is impossible in these patients. So unfortunately, the only thing we can offer them if they're stable is ovarian tissue preservation. And the second problem is that you cannot transplant this ovarian tissue later on. As I mentioned it, many centers, what they're doing right now is they are starting with the induction chemotherapy. They're doing 1 or 2 cycles, and then they are preserving the tissue. You cannot stimulate a patient after 1 or 2 cycles of chemotherapy. This is contraindicated. So the only thing you can do is you do an induction chemotherapy. The patient is stable, her blood count is good, then ovarian tissue can be done and it can be frozen. Now for later transplantation, for now, centers are using it only in experimental area, but we believe that in the future we'll have more data about the safety of this transplantation. Because according to studies, by doing chemotherapy, induction chemotherapy, the risk of cancer cells in the ovary is really, really low. And many centers are proposing nowadays to retransplant the tissue, get 1 or 2 pregnancies, and then remove the tissue entirely. And for the second question about agonists, as you mentioned, the latest RCTs came out and they reported a better natural conception rates in these young breast cancer patients. But unfortunately, the message should be that this agonist should be given as an adjunct to fertility preservation with controlled ovarian stimulation, because it is really unpredictable, the natural fertility of these patients. So even though we know now that it can help future conceptions for breast cancer patients, this should not be in place of ovarian stimulation. So what we do now is we stimulate these patients, we preserve the oocytes, and when they start chemotherapy, we give them the GnRH agonists, because it seems to have an impact on their survival, and of course it diminishes the complications associated with bleeding in these patients.
Yes, it's clear. Thank you.
Thank you.
Another question for Dr. Houssam. In which cases we have to operate on endometrioma? Is there an indication for fertility preservation in superficial endometriosis?
Yes, it's an excellent question. In which case you should operate? Definitely not for fertility indications. If the patient is presenting for acute pain, for chronic pelvic pain, and you have to do surgery for her, that's fine, you have to operate. But the only important condition is to be operated by experienced laparoscopist, mainly, not by a general. Me personally, I don't operate on endometrioma because I consider myself as an experienced one. For stage 1 endometriosis, usually stage 1 endometriosis, the discussion here, it's mainly a discussion when to offer social egg freezing. So if the patient is considering fertility preservation for social egg freezing and having mild endometriosis, it's an additional risk factor and an additional factor to take into consideration to consider egg freezing for her or fertility preservation, especially if she has low AMH or low AFC. But deferring the fertility preservation for a couple of years, for example, if the patient is 30, deferring it to 35, it might be reasonable. But here we are taking the risk of having a lower number of oocytes collected. So if the patient is with endometriosis and she doesn't have any plan to get pregnant soon, then it's reasonable to offer her fertility preservation immediately.
Thank you, Dr. Houssam. Dr. Azoury, what is the upper age limit for oocytes preservation?
Normally, in practice, it's better to do between 32 and 38 years old, because after at 40 and 42, we have less chance of good eggs, and we need more eggs to have a good result. So it's better not to pass 38 years old. And also we give a hope that if a woman present at 41 and 42, we can say that one frozen one egg, she can give her 3% chance of pregnancy. So if she came at the age of 40, 42, we give us 3%. At age of 35, one egg gives 6% chance of pregnancy. So when she came before 32 and 38, it's better.
The earlier.
Something very important for the endometriosis, I think. The most important thing with the endometriosis, when we stimulate without removing the endometrioma, I think it's recommended not to transfer the same cycle, the embryo. It's better to freeze the embryo and we transfer the next cycle and we delay the transfer of the embryo. I think this is the good recommendation when we have endometrioma, not to transfer the same cycle. You have, I think, better result in implantation rate.
Okay. Another question for you, Dr. Azoury, regarding the outcome about the cryopreservation of oocyte and embryo. Is it the same results when you freeze oocyte and when you freeze embryo?
I think the embryo, it's better. Yani we have with the embryo, we have 98%. With eggs, we have 90% when we freeze and so for survival rate. So the embryo a little bit better than the eggs freezing. When you have the chance to freeze, it's better to freeze the embryo, not the eggs.
Okay. Any live question? In which cases we have to operate a patient with asymptomatic endometrioma?
I don't think we should operate on asymptomatic endometrioma, honestly. Unless it's a very large endometrioma, and we have main concern that might not be an endometrioma. That's what I see from general gynecologist point of view. And for fertility, we're a little bit much more reluctant on operating on endometrioma. What do you think, Dr. Abitayeh, about it?
The cutoff of Dr. Abitayeh for infertility and endometrioma.
I think the indication to operate endometriosis is only pain. And normally the pain, we have it more in deep endometriosis, not in endometriomas. Normally, if you have inoculated endometrioma, we don't have a severe pain. So for infertility, I think we don't need to operate if it's not symptomatic. We can do our freezing, our IVF, our treatment for infertility. And after this, we can operate when we finish doing all our pregnancies. We operate only for pain issue. And if it's she's young and her ovarian reserve is low, we have to avoid and to remove too much ovarian tissue before operating because we'll have a real problem after for fertility. So in infertility, I think we don't have to operate any patient with no pain, no symptoms.
Okay.
For freezing, I have just a thing for freezing. We know that freeze embryos have better results than freezing eggs, but I think for ethical issue, if we can freeze more eggs than embryos, I think it will be better for the future to not have millions of embryos freezed in all the laboratories. Thank you.
Okay, thank you. A question for Dr. El Hachem. I had a case of Hodgkin lymphoma treated 4 years ago by chemotherapy and complete recovery. I did for her IVF. Her oocyte was abnormal. Is there any hope to get normal oocyte without process to oocyte donation?
You know, Hodgkin lymphoma, the chemotherapy for Hodgkin lymphoma is not really gonotoxic. Neither is Hodgkin lymphoma. So I believe what you had was probably just a chance. You know, you can have an IVF with abnormal oocytes. So if ovarian reserve permits it, I suggest you do another IVF, because this is definitely not due to, unlikely to be due to chemotherapy. The effect of chemotherapy is mostly seen in the 6 months to 1 year after chemotherapy. So even if the chemotherapy is toxic, after 1 year, you can stimulate your patient without any problems.
Can we use, thank you, Hadi. Can we use preservation oocyte for delayed menopause?
Does it mean delayed menopause?
It should be for
We cannot delay the menopause.
To delay menopause or after menopause?
This is the question.
I think because there are studies about transplanting ovarian tissue to delay menopause. I think that's what she means, not the oocytes.
Yeah, maybe.
To preserve ovarian tissue and after to reimplantation.
Yeah, there are studies about that, but it is really contraindicated because there is nothing to gain from delaying menopause with cryopreserving ovarian tissue. But there are reports about it.
From Dr. Bushra Al-Musawi, maybe it's easier to tell the name of the doctor, he can interfere. Recurrent 6 centimeter endometrioma in fertility woman shall be operated or start IVF directly, and which protocol?
Definitely not to operate, because the damage will be much greater after repeat surgery, and studies didn't show any benefit for repeat surgery for endometriomas for the sake of infertility. Definitely not to operate, and to start IVF with the regular process with the antagonist or short antagonist protocol, because the long suppression, it was based mainly on one small meta-analysis study published in 2006. So just go ahead with IVF, that's it. And probably better to do a frozen cycle, not a fresh cycle, as Dr. Azoury suggested.
Okay. What if you have asymptomatic 4 centimeter endometrioma with an irregular echogenicity inside it by MRI?
4 centimeter asymptomatic, definitely not to operate. Some people might advocate for surgery.
Dr. Houssam, we have an MRI with, I don't know, irregular echogenicity on the MRI. It's not very clear results.
So she has a suspicion of malignancy.
I'm reading the question from Dr. El Makawi.
If she has certain suspicion of malignancy, that's a different topic. That's a different discussion, maybe.
I will check if there is any other question. That's it. What if it's malignant? So it means there is suspicion on the MRI. This is it. And then sure, we should operate. So yes, Dr. Okay. Is there any size limit of endometrioma to operate, or you can start COS at any size?
No, we can start, but we keep in mind that sometimes it's a little bit difficult to collect the eggs from that affected site. You have to be cautious about it.
I'm trying to see if there is any more question.
We have with us Dr. Joseph Azoury. If you would like to ask a question, please go ahead.
Yeah, thank you. I wanted to ask a question for Dr. Joseph Azoury. Can the patient who decide to cryopreserve socially their oocyte, do oocyte freezing, and then later on they change their mind, like they find a partner a couple of years later, they have babies on their own, can they donate these eggs to other women and get reimbursed of what they already paid, or it's illegal and ethically unacceptable to donate these eggs?
To donate, but there is no till now a regular in Lebanon regulate to give her the chance and the right to donate. Till now, we have no legal regulation. We are asking, we spend this for to have regulation. Until now, we have no regulation to donate. But I think she can donate if we have good regulation in the future.
Thank you, Doctor.
Thank you, Joanne.
Does aspiration of uncomplicated endometrioma before superovulation is beneficial for better results?
No, definitely no, because the chance of recurrence is much higher. So what's the benefit of doing aspiration?
Okay, thank you. Let me check if okay. How much, maybe for Dr. Azoury, how much is effective and the success rate percentage for using PGD technique with frozen embryo? Dr. Khalid Ismail.
With PGD?
Yes. With frozen embryo, PGD on frozen embryo.
I think we have no data, but what we are doing, we see that we have the same success rate, I think, with normal fresh embryo and with frozen embryo. I think we have the same result in the lab. But in all, the literature, we see that the result of implantation rate with PGD, it's high, but in practice, really, we see that it's less, the rate of implantation is a little low than we see in the literature. Okay. But in the fresh and frozen, we have the same result of PGD.
Can I interfere, معلش?
If
the embryos frozen at day 3.
Junior, the responsible of lab in the
lab question. So if the embryos were frozen at day 3, it's very easy to thaw them, do the PGD on day 3, and then transfer them back at day 5. So there will not be an issue. The issue is if the embryos are frozen at day 5, then we have to thaw them to do the PGD. Then we have to freeze them again. And for this, we don't have data about their survival. There's not enough data about like freezing and thawing twice and doing a PGD. I personally think it would be too invasive on embryos. But they might survive it, but we might lose some embryos too.
You want to freeze the day 5 embryos because you need the results of PGD, and this is the maximum you can transfer on day 5, day 6. That's it, yes?
Exactly.
Yes.
It will require 2 days to have the results for the PGD.
Better to freeze on day 3.
Okay.
Perfect.
Perfect. I think it's perfect. Dr. Abitayeh.
So thanks for all attendees to be with us tonight, and hope you enjoy our third webinar. I want to thank all our speakers, Dr. Azoury, Dr. Houssam, Dr. Hachem, for their clear and successful presentation, and a big thanks for our chairman, Dr. Abi Zeid, for all her efforts. Big thanks also to Merck and its team who help us to make this webinar happen. Thanks for Sciences Po for all its technical support. We are waiting for you for our next webinar on the 10th of June about implantation and uterus. So don't miss it. And thank you again to be with us tonight, and good evening, and كل عيد وانتم بخير ورمضان مبارك. Thank you to be with us.
Thank you so much. Thank you. Bye-bye.
Thank you.
Bye-bye.
Bye-bye.